in Palo Alto.
I don't know any of these people.
You don't know any of them? I think I've seen one or two of them before. Hey guys, how are you?
Great, great. Yeah, thanks for having us, Raj. Thanks for Kesh. Yeah, great job moderating the World Day events for ASRA. I hope our audio is coming through okay.
Yeah, you sound great. Yeah, and you guys are going to be talking about, actually, Rakesh, why don't you introduce this section of our World Day, and then we'll let Ed introduce his panelists, and then let them take over the conversation.
So, yeah, this is a couple of panel sessions back to back, mainly as a more of a fun interactive session, and I'm a big follower of Ed's work throughout my life. So this is like to learn how he has made education fun and more relevant. So yeah, I'll let Ed lead the talk and introduce his speakers and lead the way.
Well, fantastic. Well, thank you both, and thank you so much to the organizers of the ASRA World Day events, as well as to ESRA, really, for pioneering this concept of really bringing regional anesthesia education across the world. So we're very fortunate to participate. I'm very excited to share some of our thoughts. As Raj had mentioned, we've tried to incorporate a number of different interactive types of sessions that hopefully take a break from some of the more didactic related presentations during all of these different World Day events. And I'm joined with some fantastic faculty here at the VA Palo Alto and Stanford University School of Medicine. Some I've known all of these people for many, many years. I've known Raj, I've known Rakesh for many years. And I think that it's always fun to get people together who are really passionate about what they do professionally, because I think it really helps to reinvigorate your interest, I think, in doing what really makes a big difference for patients, and it really helps, I think, hopefully keep you excited about your career. So I'll introduce people briefly from starting on my left, moving on down the row, and then I have some questions. I'll serve as the moderator, and I'll be asking questions to our panelists, and then hopefully if you all at home have specific questions for us, then I encourage you to put those into the chat, and that way Raj and Rakesh can help us moderate more of a discussion. But to my immediate left is Jody Leng. She is currently the program director for our Regional Anesthesia Fellowship at Stanford. She also serves as one of two counselors for regional anesthesia that represents the specialty of regional anesthesiology and acute pain medicine nationally within our Association of Anesthesiology Subspecialty Program Directors. And then to her left, we have Mariam Sarwary. And Mariam is our Associate Program Director of the Stanford Regional Anesthesia and Acute Pain Medicine Fellowship. She also serves on the Board of Directors of the California Society of Anesthesiologists, and so definitely an up-and-coming leader in advocacy as well as education. And then to her left, we have Tony Machi. Yeah, Tony is an incredible. I've actually known Tony for many years. Yeah, so he, after finishing his fellowship in regional anesthesia and acute pain medicine, he went on to become the division chief of regional anesthesia at the University of Texas Southwestern in Dallas, Texas. And then, after doing that for a number of years, as an educational as well as a clinical mentor, he went back to training to do pain medicine fellowship. So he currently is one of only, I think, 2 faculty that I know of offhand that actually serve within both of our divisions of regional anesthesia as well as our division of pain medicine. So between these 3, we have years and years and years of incredible educational experience. And I'm going to jump right in and just ask some questions. So as some of you at home may know, fellowship training in regional anesthesia and acute pain medicine in the United States is a bit different than other parts of the world in that we do have a standardized program. We have curriculum requirements that are already written for accredited programs in regional anesthesia and acute pain medicine that are applicable across the country. And as part of that type of a system, as you can imagine, there are various elements that have to differentiate fellowship from core residency training in anesthesiology. So I'm going to ask Jody first the first question. So how would you describe the current state of residency and fellowship training in regional anesthesia within the U.S.? And what additional skills do you think that anesthesiologists gain by doing a fellowship?
Thanks for asking, Ed. I'm gonna throw out a caveat that I'm occasionally glancing at my phone because I'm on regional call today here at the VA. So like I turned it on silent, but that means I have to look down every now and then. What is the state of regional training for residents and fellows in the U.S. right now? So I think resident experiences are like somewhat similar, obviously with a lot of differences. There's a lot of residency programs out there. But in general, my experience talking to a lot of residents over the years, a lot of applicants to our fellowship program over the years, generally most residents in the US are going to do like a dedicated regional anesthesia rotation, probably CA2, CA3 years. Some, I would say lucky residents get to do a more longitudinal experience, depending on, like totally depending on the program. At Stanford, we have a lot of ground to cover, a lot of places, a lot of locations to cover, and we have a lot of residents. So our residents do a dedicated rotation, usually CA2 or CA3 year, and then they have an option for like a 2-week senior elective. I would say that's actually relatively standard, relatively typical. Fellowships, so we have 60 plus ACGME accredited fellowships in the US, and then if you look at the US and Canada, there's close to, I think, 80 fellowship programs in regional anesthesia and acute pain medicine total. And there's a wide range of training among all of those programs. So it really does come down to, I think if you've interviewed or you've like seen one program, then you've seen one program. Every place tends to do things a little bit differently. With that being said, all of us that are ACGME accredited are meeting those standards. And so it's pretty specific actually, like what all ACGME accredited programs are required to do. Every program's doing that in their own way. And then there's a lot of non-accredited programs too that are maybe like a little bit more variable in terms of how much time you're spending actually doing regional anesthesia, or how much time you might be just like working in the OR as an anesthesiologist. Question 3 was, what do we get out of fellowship? Oh my gosh, so much joy, so much mentorship. I think, obviously I think about this a lot as a program director, especially now because we know what the job market looks like in the US for anesthesiologists. And so folks that are applying for fellowship really want it, which is awesome. I mean, I think all of us really wanted it because it's still an extra year of training that we all chose to go through. I think one of the special things about fellowship, and this I learned from one of my favorite faculty members when I was a fellow, Ryan Derby, if you're out there. He taught me pretty early in fellowship that like it is a luxury to be able to do a fellowship. It's a luxury to spend a year learning about this one thing, you know, that you're really interested and excited about, and you get to spend a whole year just diving deep into this one specialty, this one aspect of your career. And I think what we learn as fellows and what we try to teach our fellows is like, I think what we get across to our fellows is subtlety. It's not only all the big picture stuff, obviously you learn how to do blocks, like people are already good at blocks by the time they get here. You learn all the people management, you learn communication, and you get all the extras, the didactics and the educational opportunities. But I feel like something that you can't learn on YouTube, you know, when you go out into practice, is the subtlety of technique, the subtlety of like choosing an approach, the subtlety of like how to approach a service, how to approach not just giving good care, but giving excellent care. And I think that is what you get when you choose a fellowship. You get expertise and excellence, and then you learn how to teach expertise and excellence as well.
Right. Thank you, Jody. And I'll pass the next question down to Mariam, because we know, as we all know, not everyone does a fellowship in regional anesthesia and acute pain medicine. I wish everyone did, because it's such a great and unbelievable facet to offer your surgical care. It's just the experience, the outcomes for patients are so different. But I know that worldwide, I mean, we have a problem in that regional anesthesia is still underutilized. And so a good bulk of our education still has to be focused to trainees who will not do a fellowship, to our graduates from anesthesiology residency who go out into practice and hopefully can still utilize many of these techniques for all those deserving patients out there. And I know it's not just a problem in the US, it's an issue worldwide. So as an educator in regional anesthesia, how do you design a regional anesthesia rotation or teaching experience for residents that whom will go into general practice, or who may even go into other subspecialties, but may have use for regional anesthesia in the future?
Yeah, that's a wonderful question. And I think it first starts out by getting a sense of what are the private practices that most of our trainees go to? What do they look like? So being in contact with a lot of my co-residents and colleagues who are in private practice, what I've seemed to pick up is that the trend for use of regional has increased. And one reason being that a lot of these new surgeons who are joining these private practices trained at academic programs that had regional, which is a big shift from a while ago when some of the more senior surgeons didn't necessarily utilize regional. So now you have new surgeons coming to these private practices who utilize regional, and so they expect to come and have their anesthesiologists do blocks. And so keeping that in mind with the new generation who, that's one of the first questions I ask when our trainees come on rotation is, what do you think you're going to do after you graduate? And if I find out that they're going into private practice, then we really focus on a couple of things. The number one thing I always tell residents, do no harm. So we focus on where not to go. One of the biggest things to really focus on is the vasculature. How do you make sure that you don't cause any harm to the patient? And then after that, big picture, how to have a successful block. Because I think the longevity of regional at any private practice is having a efficient and consistent kind of block pattern. So you really want your trainees to get good at offering good blocks without causing harm. And so we start general, with the adductor. We don't go into the technical, getting exactly past the certain membranes and get circumferential coverage of the nerve, as I usually like to do. We start big picture. How do you get subsartorial, injector local, and get a good block? So big picture items, the amount of time our residents train with us is very short, in my opinion, which is another plug for why I think a regional fellowship is the way to go, even if you do end up at private practices. Having more opportunities to block, it's not just kind of knowing the anatomy and how to needle, but it teaches you, and these are things we talk about with our fellows all the time, efficiency, time management, not delaying the room, making sure communication with the surgeons is adequate and everyone's on board. So I would say, figure out where your trainee's going. If they're going to cardiac, we try to send them more to do the cardiac cases, the ESPs and the serratus anteriors. But knowing where they're going and having big picture idea of how to have successful blocks is kind of where we start.
Yeah. I think that's a really important perspective, is that being able to offer regional anesthesia, which we know has such incredible direct, observable, measurable impacts for patients. It's a real, in many ways, I think it's a real feature to offer a practice. And I think that we've heard from so many of our colleagues who are in private practices, foundational practices, as well as academics, that that having that skill set of being able to bring consistency of reliable regional anesthesia techniques it's of value, and it's also highly sought after. So definitely, for trainees who are out there, I think that really trying to focus, as Mariam mentioned, on kind of those core techniques that you can deliver very well in very high volume, especially those that your surgical colleagues have come to expect in their training, I think is super, super high value. My next question is for Tony. So I think Tony has this incredible, very diverse career experience already, because having been in a role where you've been a division chief of regional, have run a fellowship program, and then now have completed pain medicine fellowship and now boarded in pain medicine. I think that it's taken some time, but I think we've seen in recent years that we have had a much more blending, I think, of clinical practice, research, as well as education between regional anesthesia and pain medicine. But I think that you have a unique perspective. How do you see having those two fellowships? How has that complemented your own clinical practice, your own interests in academics, as well as how do you think that it's changed your perception of your role as a consultant physician?
Thank you. Yeah, I think on the one hand, the kind of more forward aspect of that would be the depth and breadth of knowledge and skills and the intersection between the fields, and that there's a lot there. And that's kind of what I expected as I made my transition. What I now kind of realize as I am transitioning in my practice and having it yet still balanced is that the more unique aspect, as I look in hindsight, is actually the human aspect, and understanding more deeply the arc that the patient is going through of their experience, and their human experience, and how I can leverage what I understand and can connect with them, whether that's as a regionalist, if I only have brief moments to meet them once, or during an acute pain service where I get to see them maybe some multiple days, but not long term, or separately if it's in the pain clinic and I have a more longitudinal experience, but that each of those moments is very important, and we have unique opportunity to make a difference with our skills in each of those different moments. So I think that's that's kind of where I've taken it, where I continue to go with it.
How do you bring that perspective to your trainees? Because I think that they too, sometimes they're just so very focused. Like when you're attending on the regional service and versus when you're attending on the acute pain service in the hospital versus when you're in interventional pain, I can imagine that the perspectives, the priorities of the trainees may differ. So how do you bring that insight to them, especially in those moments?
I think it's looking for those moments and looking for the pause when maybe I noticed that they noticed something. And maybe there isn't the time, let's say, during a regional procedure to discuss it right then, or appropriate perhaps, but we can debrief afterwards and reflect on that and talk about what was the opportunity there. Did we capitalize on the opportunity? Could we have done something better with that opportunity? And maybe more separately, when things are maybe a little bit slower, perhaps a pain clinic, there the challenge is to always ask why, to be curious, to understand the individual, understand how they got to where, to seek to understand how they got to where they are in their experience, and to understand, especially in the pain clinic, a little bit different than acute pain, but in the pain clinic, if they've reached you, they're in a real state of distress. And so to understand all the things that they might have gone through to get to that point, like on cue.
Our lights turned up. There we go. There we go. And then we'll shine a light back on you.
Yeah.
But no, I want to call out just something that you said that I think is really, really relevant, and I love it. I hope everyone at home really picked up on it. It's this idea of the pause, because I think we have so many pauses in perioperative medicine. We have this, all of our different checklists, the pre-block timeout, we have the pre-anesthetic timeout, the pre-surgical timeout, but this idea of having a pause specifically to focus on an educational element, I think that's really cool. I hope Raj, Rakesh, I think we'll have to put a bookmark on that, because I think that's something that we're going to want to revisit and really think about how we incorporate that into much of our teaching. I have a question for everyone, but I'm actually going to start with Mariam, because I know, like, for all of us who've been at this for a little while, you realize that one of the exciting things about regional anesthesia as a practicing physician is that you're always learning and trying new things, which is like one of the coolest things that I think about in terms of our subspecialty. Can you tell me, I'm going to start with you, but I want to hear from all of you, what would you say is the most exciting change that you've made in your practice as a regional anesthesiologist, whether it's in teaching or clinical practice, in the last year or so?
That is a great question. I would say the biggest change that has come, and it's been in the form of teaching, has been AI. Sometimes you get questions from residents that take a while for you to, get the answer to, and ChatGPT and AI has decreased that. Sometimes there's images I need and have trouble finding. So I would say AI has definitely changed what the day-to-day regional didactic teaching looks like. It's very easy to input information and then go through what comes out. And for any of our fellows or trainee, other attendings, it's a really nice way to get a structured kind of lecture if you put in the input, and it breaks it down in a very organized fashion. So I'm very happy about its introduction and utility in all of medicine, but especially with teaching.
Yeah, I like that. I like the idea of using AI to tackle some of the things that we don't like to do. Like I saw like a great post on social media somewhere that it was a writer, and her comment was, I really don't want AI to do all this writing for me while I still have to wash my dishes and do the laundry. Like I want AI to do the dishes and do my laundry so I can do all the writing and all the fun things. So so I like that perspective. Jody, can you tell me about one thing? What's one thing, exciting thing that you have done that's changed, maybe a new change in your clinical practice or in your teaching?
I don't know if it's new or if it's old, but like, I think like one of the fun things about being in charge of a program is you get to make decisions about how things look. And I think it's funny that, I don't know, you know, geez, it's been almost 6 years since COVID started, wildly, but I just really appreciate doing stuff in person. I really appreciate doing stuff in person. And I really try to make sure that I want our lectures in person. If we have to do a Zoom lecture, I want cameras on, because it's like, I just really value the intangibles of like being together as a group and learning from each other, versus like all the Zooms we're on with our cameras off and we're also making dinner at the same time. So I think for me, it's more of just like an awareness and a focus of like, I appreciate what's happening today. I appreciate what's happening with my patient that I'm standing here in person talking to. And then I try to like design a fellowship program and like educational experiences where we're doing as much in person as we can, because like AI is super cool and it's like adding all this technology, but I think we still just like need to connect as humans.
All right, Tony, all right, what's one exciting change you've made in your clinical practice or teaching?
First, just Mariam and Jody's comments both hit home for me too, but to pick something a little different, I'd say for me, being at this crossroads of pain and regional, that the looking for these opportunities of where they meet and how my knowledge would be able to translate both directions. And so one of those kind of ways is always seeking out when are the opportunities that I could be doing a block that might actually be even more specific. So for example, if I can get away from the motor aspect of the central motor nerve and I can make it just a purely sensory block. And because of the nature of some of what I do in the pain world, I am pushed to do that in different ways. And so I seek to bring that knowledge back to the regional world of when do I actually have the opportunity to leverage that. A lot of times we don't, but sometimes we do. And so there, I think it's pretty cool.
I mean, I think I have a very simple one. I just, in the last year and a half or so, I've just, especially for our residents, who have a very brief period of time, working with us to try to safely and effectively perform some of the most, like high yield, but sometimes concerning, or at least can be concerning blocks, like brachial plexus blocks. Yeah, I've just started teaching. I mean, it's more of a throwback. I want to credit some of our ASRA founders, like Alan Winnie, who described the brachial plexus sheath. But I teach the interscalene brachial plexus block as a fascial plane block now. And I tell our residents, especially if you're going in general practice, you're going to take care of a lot of patients who are having shoulder surgery. We know that those patients are going to have a lot of pain after surgery, and not to be intimidated by whether or not they can figure out what's the C5 nerve root or what's the C6 nerve root or what's, where does the suprascapular nerve take off. Just if you approach it as a fascial plane block, the way that Winnie described the sheath, and you can get local anesthetic into the compartment, you're going to have a good block. Your patient's going to benefit. It's also a lot less stressful, and you don't have to keep moving your needle around to potentially hit all the nerves. So my next question,
hey, Ed?
I think, and I'll start.
Hey, Ed, can you hear me?
Only because I think, I'd like to know, it's because when you get in practice, I think one of the things, for those of us in our generation where, I didn't even learn ultrasound as a trainee. So you're always learning something new. So, one of the things that I think is really critical for lifelong learning is you have to know where to get your information. So Tony, I'll start with you. So what resources do you recommend for physicians in practice who are out and whether they just finished their residency last year or they finished their residency 20 years ago? Where should they go to stay up to date in terms of what's new in regional anesthesia?
Yeah, I'm going to give a very biased response here. So, and one of the hats I wear as vice chair and editor for the ESRA News, And so I'm going to give a plug for ASRA News because I think we have a very high yield, very practical and pragmatic product that we put out. Every issue, and it's a quarterly publication online, every issue we have 6 articles that are focused for high yield clinical practice. And we always have a complement of other articles as well. But they're short, they're concise, they're efficient, and they're great for learning and spurring on more learning. It's not the end all and be all, it's the beginning of your learning journey. And it's really high quality, it's vetted. So written by great authors, vetted by great team. So that biased response, but that's one place.
As a completely biased former editor of the ASRA News, I can also endorse the ASRA News as a great product for continuing lifelong learning. I'll come back to Mariam now. So what do you recommend in terms of resources? And I think this is also very important. I think when we're as educators, for our trainees, we know that they are going to find sources on their own. So how have you incorporated that in your practice? Like, which resources do you point them to? Yes,
Yeah.
Because you know they're going to go online for resources anyway.
Definitely. Well, I think for those of us in academics, it's almost a little bit cheating. You get resources whether you like it or not. Whether, for us on regional, we have Journal Club monthly, we have grand rounds, and then for our prior practice colleagues, and I tell this to our trainees who are going to practice all the time. Again, a plug in a sense, but interacting with your societies, ASRA, ASA, CSA, whatever it may be, by default opens up resources to you, whether it's the ASRA News, whether it's the ASA Monitor. I mean, just in today's show, for anybody who joined on, they talked about the Journal Club for the trainees. They talked about a webinar series. So just interacting and being involved with your component societies will open the doors to stay up to date, most of all, attending conferences, reading, hearing about the top 10 abstracts for the year. It's also a fun way to keep up to date. So I highly encourage everyone to join their societies and stay involved.
That's right. Jody, what are some resources that you point trainees to? And I'm sure that in many ways, and I'm sure that our friends out at home also probably have the same experience. If you've been an educator, then your former trainees they'll get in touch with you for the rest of their careers. So when people are asking you for information and asking you where they need to go to get the latest resources, where do you point them?
Yeah, I mean, agree with ASRA News. I really do like ASRA. I'm kind of basic. I think just wrap them. It's a great term. Not to say wrap them is basic, but I think it's like it's just like an obvious choice for a regionalist for good reason. I think that's like a great place to see the latest. And I do I guess I'm like on an in-person kick today because I like a meeting. I like to go somewhere and hear a person talking to me and about their latest research or about I don't know, like on a panel talking about their approach to things. So for me, that meeting is usually, there's like an education meeting I go to learn specific stuff about education and anesthesiology, but then also, plug for ASRA. I'm just like, this is so predictable. I'm sorry. Yeah. I would say the other thing though, I mean, if you're someone who's just gone out into practice and you're like, I don't know what block to do, or this isn't unusual, like you can, you do your Google search or whatever, but like, don't be afraid to text your old attendings. Like we get these texts from our recent trainees, like, thank goodness, that's what we like, and then we can troubleshoot with you. So don't forget the folks who trained you, their job is to train you for the rest of their lives. So it's another good resource.
Yeah, I think it was a big mind shift for me. I think at some point in the last few years when I just stopped pretending that our trainees are going to go to the same resources that I used when I was a trainee. They're not going to necessarily go to the journals and read the articles from beginning to end, or go to the textbooks. And they're going to get the information that they can get from the most powerful source of information they have, which is their phones in their pockets. And I think it shifted my view as an educator to say, maybe part of my job is to curate that information. Is to say, in the universe of all the internet-based sources, here are the things that probably are the most validated and worthwhile. And so, like, I mean, here we are on YouTube. I mean, I think on YouTube, I recommend, highly recommend. Yeah, I think Duke's YouTube page is fantastic. You know, a lot of just-in-time videos. They're done very well. Yeah, they follow very safe techniques, and they can be performed. You can observe them, you know, just before you're about to see a patient. Yeah, I recommend, so there's so many high quality lecture based YouTube channels as well. I mean, I think at least in regional anesthesia, I mean, I look at Professor Kichin Chin and Amit Pawa, Vicente Roques Escolar. It's amazing content, really with some of the same high quality lectures that they give at international conferences, like all year round. And then, of course, I was telling our fellow yesterday when we were working together that like if I'm driving in and there's a new episode of the Block It Like It's Hot podcast, I'm listening to it. I think Jeff Gadsden and Amit Pawa have done such a nice job of just combining education and entertainment. Their latest episode was one of their interviews from the most recent ESRA annual Congress. And a lot of those conversations, these aren't conversations that we'll necessarily have with the same people ourselves. And so to actually hear that kind of very organic discussion about topics that have relevance to our patients and our practices, I think it's incredible. You're not going to get that information anywhere else. So I think I'll invite Raj and Rakesh actually to come back and join us, just because I think we have some questions and we'd like your input too. So I was going to ask everyone, but you two are included. Since we were on the topic of like former trainees reaching out to you all the time, because that's what they do. What's a question that you recently got from a former trainee that's related to their practice, at least in regional anesthesia? I'll start with mine. I know, like, I regularly get asked from former trainees, just is because in the US, we have this process of procedural coding. So I'm always asked about, well, what code should I use for this, or what code should I use for that? Because not much of our healthcare economics, the state of healthcare economics, is really taught in residency and fellowship. How about you guys?
I'll let Raj go first.
Yeah, I mean, I don't know if I think people ask me questions because this is usually what the vein of what I talk about a lot during their training. So they go back and ask me those types of questions. Most of what I get are about, like, how do I introduce a new type of service into my practice? What is it that makes that valuable to that institution or that surgeon, or how do I convince them that it's a good idea? They read about a new block, or they read about something, and then they ask me, like, how do you kind of implement that? That's kind of my bailiwick when I talk to them about stuff during their training program. So I think that's probably what resonates or makes them think of me when they're reaching out. And then, of course, people still, even though we create the apps, people still ask me questions about anticoagulation. So they'll call me, and I'm like, well, just look it up. It's right there. But there's always a gap in someone's, in the guidelines somewhere. They managed to find that one situation that wasn't written about, and they'll call me about that.
Actually, that's a good one, because I was citing a paper that Rakesh had co-authored just the other day, because we were talking about the Canadian Regional Anesthesia section's consensus recommendations on bleeding risk using the CIA score. It's like, how critical is it? Is there an intervention, and how easy is it to assess? And that was just such a nice way of taking the ASRA guidelines we have and filling in some of the gray area, right? When you have that patient in front of you that's somewhat complex.
Yeah.
Rakesh, what have you been asked by a former trainee?
Similar to what Raj has commented, mostly to know procedural aspect of newer blocks, blocks which we did not get an opportunity to teach. More recently, many of my previous trainees have been asking about stellate ganglion blocks, how to do them, because I think it's getting more popular in practice, especially in the cardiac realm, or when they land up in complications. Because that's not the training we do not give in real time. So we talk about all these hypotheticals, but when you actually have a complication, people don't know how to react. People don't know how to manage it because they've never had it in their life, these rare events. So when a patient has a neurological symptom, that's when I get a phone call from my trainee saying, hey, what should I do next?
I mean, I think to Jody's point, I mean, really, that is one of the things that you really get from having that close interaction with your teachers and your consultants over the course of your training is you do build up this professional network that you have your whole life, because it is scary. I mean, I think it's not an if, it's a when, and things happen. They've happened to all of us, and we earn these badges over the course of our professional lives as physicians, and it's nice to know that you have the support from someone or many someones just at your fingertips.
So Ed, I'm gonna to wind down this panel. I'm gonna actually share a question from our good friend Jerry Jones, and this is directed towards you. You get to answer this one. If you had more time with fellows, what is the one thing you wish you could add to their range of insight, not knowledge base, transitioning from academic to private practice setting or culture in particular?
Yeah, I mean, I think Jerry's absolutely right, and thank you so much, Jerry, for the question. I think that there definitely, if there was something that I could try to impart on our fellows before graduation that sometimes I don't think we emphasize quite enough, is I think it's a bit of a combination of what all three of our panelists have talked about today. It's really that longitudinal perspective, that puts the patient in the middle, but like looks at where you can look at your role as a consultant physician as someone who really adds value to their care. I think that it's very easy to get so overly focused about where you put the needle, or how to get the best view with the ultrasound when you're in a regional anesthesia fellowship. I mean, intrinsically, like, it is very technical, but I think that the emphasis, sometimes I think we hear them referred to as the soft skills, but they're not soft at all, right? I mean, they are the most critical skills we can teach a consultant physician, and I think to impart on them, I think how the value that they can bring to the individual patient, to their system, and even as a representative of our great specialty of anesthesiology is something I would love to have more impact on many of our fellows, residents in training, as well as they transition to their practice.
Well, I want to thank all of you guys, Ed, Jody, Mariam, Tony. You guys are always great to listen to. So much incredible talent and insight and knowledge in that one room at that end of the table. Wonderful to have you here. Join us on the World Day of Regional Anesthesia. And I look forward, hopefully, to see all of you in Phoenix for the spring meeting. As Jody says, it's nothing beats an in-person get-together. And as I've always told everyone, I think the best time at these conferences are usually in the hallways. So I look forward to seeing you guys in the hallways and chatting up some more. Thank you for joining us.
You too. Yeah, thank you so much for hosting this great event. It's a pleasure to be part of it. We look forward to seeing you again soon.
All right. Talk to you guys soon.
Thank you.
Bye.